Hello, I'm Michael Brown, Master's of Science in Healthcare Management, class of 2007, and currently chair of the Alumni Weekend Committee, speaking to you from my home in Arlington, Massachusetts. Even in this virtual format, the committee felt it was so important this year to keep one of the signature sessions of Alumni Weekend, and that is the lightning talks. These short talks given by alumni are an opportunity to hear stories from one another, and this year we have chosen to share stories related to the COVID-19 crisis and response. Dr. Mary Brindle is a pediatric surgeon in Calgary, Alberta, and health systems researcher. She completed her undergraduate degree in art at Yale University and received her MD degree from Dalhousie University in Halifax, completing her general residency in Vancouver and her pediatric surgery residency in Toronto. She completed her MPH at the T.H. Chan Harvard School of Public Health in 2013. She is currently the Director of Research Arm at Alberta Provincial Surgical Strategy and the Director of Safe Surgery, Safe Systems Program at Ariadne Labs, T.H. Harvard School of Health in Boston. Mary has helped to lead efforts to address the impact of COVID on surgical systems both in her province and internationally, and will speak about her experience as a surgeon and a researcher. She'll be sharing her experience with you today. Mary?
Thank you so much. Good morning. I'm a pediatric surgeon living and working in Calgary, Alberta. Our center is located at the foothills of the Rocky Mountains at the western border of the Canadian prairies. My hospital sits in one of the largest urban centers in Canada, serving a catchment area of about 2.5 million people. A pediatric surgeon's job is characterized by urgency, whether it is an operation on a neonate born with a life-threatening condition or a teenager who's been terribly injured in a motor vehicle collision. Our specialty is familiar with rapid decision-making informed by best evidence, qualities that ended up being very useful when confronting the pandemic. The other side of my work is research. I run a research lab in Calgary, and I'm director of the research arm of our provincial surgery strategic network. As COVID began to spread across the globe earlier this year, I was preparing to take on the role of director of safe surgery and safe systems at Ariadne Labs, which is a joint center for health systems innovation at Brigham and Women's and Harvard T.H. Chan School of Public Health. Now, Ariadne Labs focuses on a long arc for research innovation, building strength on rigorous design, testing, global scale, and spread. In the middle of one of our busiest times of year for surgery in Calgary, we became aware of the possibility that what had initially appeared to be a local viral outbreak on the other side of the globe might threaten our surgical systems in a way that we had never considered possible. As my colleagues and I watched the spread of COVID through Asia and Europe and into the Americas, we were urgently trying to determine how we would approach the pandemic. Our awareness and knowledge of the pandemic was evolving at a rapid pace, and we had so many stories but very little certainty. We saw healthcare workers donning hazmat suits effectively in China. At the same time, we heard about Italian doctors who ran out of PPE and continued to care for patients until they eventually became infected and died. In my province, non-urgent surgeries were immediately postponed, but we still had patients requiring surgery every day. Patients were afraid to come to our hospitals, and across the country there were delays in people seeking medical attention. And sometimes these delays proved fatal. My fellow nurses, surgeons, and anesthesiologists were afraid that our PPE would be rapidly consumed, and they were also afraid that the PPE that we had at the time would not sufficiently protect them. Many of my colleagues in medicine created wills for the first time. As a community, we were sequestered and we were fearful, at work or at home, and in response to the uncertainty and the need, many of us wanted to do something more. And in particular, a lot of us really wanted to get involved in the COVID response. So at that time, my department head asked me to organize the setup and flow of the OR systems in our hospital in Calgary. And this request came at the same time that I was starting my work for Ariadne Labs. And what we wanted to know in Calgary was exactly what my colleagues wanted to figure out in other parts of the world that were just starting to see their first cases of COVID. Now, places like Singapore and Hong Kong had already responded, and they had some lessons that they'd retained from earlier epidemics. And some of these early experiences were already published, such as this paper that came out of Singapore It was really put out in early March, and this ended up being something that was really useful to us. So I approached Atul Gawande from Ariadne Labs, and he and I put together a set of recommendations that was based on the best available evidence that we could find at the time, and what we found was working well in places that had already seen the first wave of COVID. And we really rushed to try and get this perspectives piece out relatively early. And so we got this out by about mid-March. And it was recommended by the American College of Surgeons. And I think because we were able to get this out relatively early, it formed the foundation of many care strategies that were being developed in different countries and systems that were starting to look for a blueprint to confront COVID. In fact, it was actually the initial draft of what I ended up working on for operating rooms in my city, and eventually what we ended up developing for the rest of our province. So the piece that we published basically had 7 recommendations for those setting up operating systems to deal with COVID at its outset. And these recommendations now, I think, seem relatively simple. One was to prepare for a rapidly evolving situation, to postpone the elective operations immediately so we could regroup and plan, to develop a plan for essential operations during the pandemic itself, what surgeries needed to be performed, to educate all the staff on PPE use and COVID management, and to decrease the unnecessary exposures of healthcare staff, such as trainees and more senior, potentially retired staff, to develop a dedicated COVID operating space, and to prepare for repurposing OR spaces for critical care use. Now, the area that I ended up spending quite a lot of time on at the very beginning was number 6, which is developing the dedicated OR operating space, simply because there was a lot of things that we ended up needing to do to make the spaces in which we worked work for COVID. And these were the basic things that we ended up looking at and recommendations that we made. One is that there should be a specific room used for COVID cases, that unnecessary items should be removed from those, traffic in and out of the room should be minimized, that the patient should be recovered in the operating room with dedicated staff, and that we should keep the pathways clear during transfer of patients with COVID to and from the operating rooms, that we should consider how we might modify surgical approaches to minimize our risk, and above all, to recognize that all these care pathways should really be adapted for local context. So I joined operational leads at the time, operational leads from across Alberta in infection prevention and control, surgery and anesthesia, and we visited ORs many times in person, but also virtually, taking photos, meeting with teams. We talked through care pathways on paper. We walked through physical spaces, tracing out patient pathways, as well as determining how spaces might be transformed for possible ICU. We wrote and revised and reported recommendations quickly because the centers were very eager to adopt our best practices. And one of the things that we found out is this was not a single event. It required that we meet every day to address feedback, develop revisions, monitor our successes, and identify where our systems were failing. And throughout this time, we focused a great deal on communication. And one of the things I think was very effective is we held web-based town halls for all of surgery and all the surgical teams across the province. In Alberta, we're very lucky. We have a single centralized system, so we could create a single unified approach to support a population of millions of people, while at the same time allowing for local implementation and adaptation in hospitals across the province. Despite the fear that we had at the beginning of the pandemic, we've yet to have a single case of transmission during surgery. But of course, we realize that the risk is far from over at this point. Now, my research didn't stop during COVID, and if anything, it felt more critically important and started to resemble more closely the urgency and pace of my clinical work. In much of North America, medical research was largely put on hold, but for health systems research, I think this is necessarily different. The need for systems-based responses to the challenges of COVID are clear. We knew that we needed to pivot from our large-scale multi-year projects to address the immediate needs of a global community. But this is not an easy pivot. Research work can be exciting and innovative, but it is slow by nature and design. From our various isolated locations, our research team came together. We identified needs and opportunities to synthesize existing knowledge and also to create new knowledge however we could through surveys, interviews, and quantitative data. The balance between providing urgently needed information while ensuring that it's accurate and reliable, I think, was keenly felt by our team. Much of the learning from the responses of our system to COVID will also be retrospective. We're currently exploring the approaches that have been used to effectively redeploy and onboard healthcare workers during crisis. We're working to understand how we can best triage non-urgent surgical cases. The need to act without complete information has been necessary, but there are opportunities to learn from these actions. We've interviewed healthcare leaders from the US and across the globe who are shedding light on some of the unanticipated challenges in uprooting and reorganizing entire systems, while the people in those systems are dealing with fear and loss. Understanding how to optimize care during a crisis will remain important during and beyond the pandemic. And understanding how some of the adaptations of the pandemic will establish themselves in the new normal of healthcare is important. Critical challenges can remind us of how dynamic and exciting health systems work can be. They sharpen our focus on why this work is important and the limitations of what we know. They also give us an opportunity to address our responsibilities as a physician to improve whenever we can the systems that care for our patients and their communities. Thank you.
Thank you, Mary. That was wonderful work. If you don't mind, I'd like to ask you a few questions.
Of course.
In your talk, you mentioned the benefits of having a single unified system in Canada. Can you elaborate on that a bit more in terms of how that helped in the response to the pandemic?
I think there's a lot of ways. I think particularly at a point when information is coming at us relatively quickly, and the degree of response, I think, could be quite variable. So that we kind of had a shared understanding of what was basically required, and that could be basically spread out almost immediately across every health system. And also, if we needed to shut down certain centers so that we could centralize our resources in a single center, that could be done quite easily. Plans to shift patients, that was relatively straightforward. I've got to say, I think the most important thing, and this is really what I've gathered from talking to people in other health systems where you may work within a city that has numerous hospitals that all have different approaches, is that you get a little bit less of that fear and uncertainty from seeing someone who's just down the street do something that's very different than what you do. I think to be able to bring people together where everyone feels like we're all doing the same thing, we all have some evidence behind it, we understand it, I think that it goes a long way both to ensuring consistency, but I think also diminishing fear quite a bit.
Wonderful. The second question is, clearly you were part of such a strong response to the pandemic. Having gone through this experience, do you think the system will be different going forward in ways unrelated directly to the responding to the pandemic?
I do. There are ways that I hope it will be different. And part of those have to do with a potentially a belief in the value of health systems work, health systems research. Some of these things that I spend a lot of time thinking about and working on, which are things like the surgical safety checklist, for example. I think that there may be a renewed interest in some of these tools that bring people together and ensure good shared information and communication, because I think people have seen how well it works during the pandemic itself.
Great. And as the last question, challenges like this can bring out the best in people. What lessons in leadership did you learn from this experience?
Well, the one thing is that first of all, you realize that leadership, I think, comes from a lot of unanticipated areas. And I think about the team that ended up coming together to do a lot of the work that I was involved in our provincial response. And some of those people, one of them in particular I recall is an anesthesiologist who was working in Calgary, and I think just had a real passion and interest for doing the work and was really interested in collaborating. So kind of these leadership skills came out. Some of the areas where you might traditionally think that leadership would come from, like department heads and such, they were so busy and bogged down with other things that we actually had to bring in, I think, developing leaders or people who had all of this potential from other areas. So it was, I want to say it was a really, really great opportunity to sort of start seeing emerging leaders come through in our system.
That's wonderful. Well, I want to thank you for your talk today and for all the work you're doing, and invite our guests to check out our other lightning talks to hear from other alumni who also had a role in responding to the COVID-19 pandemic. Thank you, Mary.
Thank you.